Well, it's exactly on the 00 hour of whatever hour you are in across Europe. So you're all very welcome to the second in our series of webinars of the Europe region of World Physiotherapy for members of member organizations. The idea for these webinars arose at the general meeting of the Europe region last year, and this series has been implemented by the professional practice work group of the region and is led by Neerit Rotem, who will lead the discussion tonight, along with Alex Mackenzie, who will moderate the questions. The theme of the webinar, as you know, is COPD. I suppose this is an enormous area for us as physiotherapists, and one in which we make an enormous contribution. The format for tonight will follow the same format as the last one. We'll start with the short presentation on the guideline from the Dutch Association, the KNGF, which Emmylou Beckman will present. And then we will hear the experiences of our panel from across Europe in treating people with COPD. And again, these will be just brief presentations from our experts, from Chris Burton from Belgium, from Yedidia Silverman from Israel, and Henrik Heinsen from Denmark. And we're leaving lots of time for questions and views. So we want to have a discussion among the panel and between the panel and yourselves. So please use that chat to put in your questions so that we'll have a good and active discussion. So welcome again, and I have pleasure in handing over to Neerit to lead the session.
Thank you. So thank you to all who have joined us. This is the second webinar we're having on behalf of the European region of World Physiotherapy. And the aim of the webinars is to share knowledge across the region and promote the use of guidelines in practice. We also wish to talk specifically about physiotherapy in conditions that affect many and have high societal value and impact. One such condition is obviously COPD. It has a global prevalence of about 10%, and the European prevalence is around 7.5%, and it often involves hospitalization and a very high mortality rate. Physiotherapy is and has always been an important intervention in COPD in the community setting, acute care, and for quite a few years now in pulmonary rehabilitation. So we will try to cover some interesting topics of treatment with the help of our panelists, which are Henrik Hansen from Denmark. He's a physiotherapist, PhD and postdoctoral fellow at Respiratory Department and Research Unit in Copenhagen University. His primary research area is exercise intervention studies, RCTs, and new rehabilitation models, including optimization of outcome measurement in clinical intervention trials, research, and clinical practice. He is co-authored several systematic meta-analyses and is a former guideline advisor. He'll talk about the role of Tele Rehabilitation. We've got Chris Burton from Belgium, who will talk about the possible role of partitioned exercise. And Yedidia Silverman, who has experience in working from Israel with patients with COPD in the acute care setting, including ICU, and is now working in the community in Maccabi Health Services as respiratory physiotherapy lead in the central region. He'll talk about the continuum of care. And Alex Mackenzie will bring in your questions from the chat, and you are invited to post them whenever you have a question. But we will start with Emmylou Beckman from the Netherlands, who is a professor at the Research Center for Autonomy and Participation for persons with chronic illness, and a senior teacher at Academy Physiotherapy, Boston University of Applied Sciences. She is a registered physiotherapist and the author of the Dutch guidelines, which she will present. Just before we start, I will use the opportunity again to thank the KNGF, the Dutch Society, for producing the very high quality guidelines and translating them to English so we can all be able to use them. So thank you, Emmylou, and your society. And Emmylou, if you will, you can start with your presentation.
Yes, thank you so much. Thank you, Neerit. I'll share the screen with you. see. So welcome and thank you. Thanks to the organization for having me here tonight. Well, this presentation is about the development of the revised KGF guidelines on COPD in the Netherlands. Thank you for the compliments. We are very happy to share them in English. To click to the next slide, but it doesn't work. Let's see. We just tried it. Try it again. Yes, here we are.
Yeah.
I hope you can all see my slides. So I was already introduced, but my main focus lies in the triangle of research, education, and practice. And I did my PhD research in the field of physical therapy and COPD. And I use this expertise as the author of the Dutch guidelines. So these revised guidelines were funded by the KGF, the Royal Dutch Society for Physical Therapy in the Netherlands, and also the Dutch Ministry of Health, Welfare and Sport. Those involved in the development of the guidelines are mainly methodologists, scientific researchers, but most importantly also the physical therapists, and in the Netherlands also the exercise therapists, Cesar and Mensadik. So we did a joint venture between two professions here. Also the physicians, other healthcare providers, and for example, the healthcare insurance were all sitting around the table. So it was quite a fun discussion, you can imagine. At this moment, only 5% of the patients with COPD make use of physical therapy in the Netherlands. And this number is very low, consider the scientific evidence for effectiveness of physical therapy. As you might know, this study by McCartney and colleagues concluded in their Cochrane review that the cornerstone of pulmonary rehabilitation is exercise training. Physiotherapy or physical therapy, as it is provided by Dutch therapists, reflects this way in this publication of exercise training that is described in the Cochrane review. And they also conclude in this review that more research to the effectiveness of pulmonary rehabilitation with exercise training as the most essential element is not warranted because there's enough evidence, and that future research should be focused on the content of the treatment. So therefore, a lot of improvement is necessary to improve quality of care in patients with COPD in daily practice. And the update of our guidelines from 2008 on COPD was an essential step for us. So for the development of the guidelines, the KGF works according to the international standards in guideline development, like the GRADE method. The first step in guidelines process is the preparation phase. So here I'll just talk a little bit about the methodology. We identified barriers in current practice, and based on these barriers, clinical questions were formulated and answered. And these answers are the recommendations in the guidelines. That's actually the second step, the development. Well, to formulate these recommendations, we made use of international literature, but also of considerations by guideline panel, which includes therapists, primary, secondary and tertiary care, and also other healthcare professionals. It also included patients and other stakeholders. The third step that we took is the review and authorization phase. Well, in this phase, a large external review was conducted by stakeholders like general practitioners, corporations, but also by the field tests with several physical therapists. And at the end, all involved stakeholders were asked for official authorization of the physical therapy guidelines. So also pulmonologists and general practitioners all agreed on this guideline. The fourth and final step is the implementation of the guidelines, because it is important that therapists and other healthcare professionals, patients know how to integrate these guidelines into daily practice. And I believe that is the key, actually, the final step. And tonight, you are actually part of this step. The KGF guideline COPD was published in 2020 and includes many topics, of course. Well, in this presentation, however, I will focus on the most innovative recommendations in the Dutch guidelines, and I will just address the treatable treats by physical therapy, the measurement instruments that we recommend, the CPAT, the cardiopulmonary exercise testing, the patient profiles, which I think is a huge and innovative element in this guideline, and a little bit about the interventions. So how did we get to the recommendations that I will present to you? Well, barriers in current practice were identified regarding the former guidelines on COPD, and therefore we organized several focus groups with physical therapists and patients, and based on these barriers, clinical questions were formulated to be answered. Well, the answers to the clinical questions, they form the recommendations. And for the answers, we used all available literature. All available literature was searched and studied, but not only literature was involved, because to go from biased, to go from evidence-biased medicine, only examining RCTs and reviews, towards evidence-based medicine, we did not only include literature, but we also took considerations into account, like quality of the evidence, balance in desired and undesired effects, patient's perspective, the professional perspective, costs, healthcare organization, and societal perspective. So for all topics in this guideline, both literature as well as all the other considerations were involved of all the stakeholders to come to this new guideline. Well, as stated before, we formulated some clinical questions, and these are two examples of those clinical questions we formed. Why do I use this as an example? Well, as stated before, evidence on the effectiveness of exercise training is abundant. However, how to distinguish different types of patients to provide the patient with the most adequate care, that's unknown. And physical therapy is not a one-size-fits-all principle, as you all know. Physical therapists make choices for their focus in the treatment of patients with COPD. However, there was no consensus on how decisions were made. So therefore, among other questions, we formulated these two questions on the treatable traits and on the stratification of patients in order to give appropriate physical therapy care with the right components. So like more personalized care. For the recommendations regarding the treatable traits and patient profiling, a literature review was conducted. However, the literature was limited. So the expert meetings were conducted with the clinical panel, the review panel, other experts in the field, as you can see here, in which important elements regarding the patient stratification were discussed. And our goal was to construct a model to stratify patients with COPD, which was widely supported by physical therapists, other healthcare providers like pulmonologists and general practitioners. So this was our method, how we came to that. So let me talk about the treatable traits. The treatable traits were determined with the help of recent literature. Within the domain of physical therapists, the focus of treatment lies within the physical functioning of the treatment of the patient. That was our key. Well, experts agreed 3 relevant treatable traits within the domain, and you will see them here. Coming from the physical functioning, we know the physical capacity and the physical activity. Those were considered as the most important traits to stratify patients for providing the most relevant care. Nowadays, we know that physical capacity and physical activity are interrelated, but one doesn't lead to the other automatically. And to illustrate the importance of stratification based on physical capacity and physical activity, I want to show you a figure. It comes from the study of Poland and colleagues. And within this study population, patients were stratified based on the capacity. You will see that on the horizontal axis, what a patient can do, and the activity on the vertical axis, what a patient actually does in daily life. Well, these variables were measured with a 6-minute walk test for capacity and the number of steps with an activity tracker, steps per day. So maybe it's a nice question for the audience. Where would you place your own patient? In which quadrant? Just keep that in mind. Well, in this figure, I will show you what comes from this study. Each dot represents an individual patient with COPD. This was based on a cohort of 262 patients with COPD. And there are two things to notice. First of all, there is a difference in patients that it shows. Every patients are there in every quadrant. And second of all, there is a correlation, but it is really limited. Correlation between physical capacity and physical activity. So it is very important to distinguish patients with low physical capacity from the patients with low physical activity to focus on the intervention. After all, it is not effective to train a person who already has a sufficient physical capacity, and it is not effective to stimulate behavioral change in a patient who is already very active. So we have the 4 quadrants, and I'm really curious if you recognize patients in your practice in every of these quadrants. In the upper right one, for example, you see the can-do, do-do patients. That's the most desired group, and maybe we don't have to do much with this group in physical therapy practice. In the lower right corner, we see, however, a really interesting group, the can-do, don't-dos. In this study, we also noticed that this is the group with more metabolic treats. So there's something to do with diabetes as well in this group. In the left upper corner, we see a group that can be mentioned as the can't do do-dos. So the people were a little bit more younger, for example, had to do some more physical activity because of their work or a partner. And then in the left lower corner, we see a group with 2 treatable traits for us as a physical therapists. We need to focus on training the physical capacity, but also behavioral change for physical activity. So apart from the distinguishment between the physical capacity and physical activity, experts stated that the degree of complexity in differentiation of patients should be determinative for the setting in which a patient should be treated. Interdisciplinary rehabilitation versus primary care versus information and advice on lifestyle only. They can be distinguished. Well, to define the complexity, the severity of an exacerbation and the burden of disease are relevant factors, and we took them into account. The burden of disease, how to measure that? Well, this is the figure with all the recommended measurement instruments. And before, in the guidelines in 2008, we had about 16 or 17 recommended measurement instruments, so we reduced that number. And we only looked at those measurements that will influence our practice as a physical therapist. The burden of disease should be measured with the CCQ or the CAT. Other recommended measurement instruments we already mentioned is the 6-minute walk test to get insight into the physical capacity, and also the activity tracker or activity meter to get insight in the physical activity. Of course, for monitoring the oxygen saturation, a saturation meter is necessary. And in the Netherlands, we also recommend the PSG, that's for treatment goals aimed at activity and participation. And this is the patient-specific goal setting method, and that is recommended in the Netherlands here. Finally, you will see here the CPAT, the cardiopulmonary exercise test. And you see that next to the 6-minute walk test. I will come to that later, but it's a recommended test, but not for all COPD patients, only for those groups that have insufficient physical capacity. And that's how we also got the general practitioners involved, because otherwise they will get crazy here in the Netherlands if we have to do this test with every patient. So why the CPAT besides the 6-minute walk test? Well, you can see here how the cardiopulmonary exercise test differentiates itself from other measurement instruments like the 6-minute walk test. And you can see, for example, that only the CPAT can recognize the most limited factor in a patient. And for example, can this test is the maximum test that can determine whether the physical activity is safe. So there are some pluses in the other tests as well, but the CPAT is the only test that can tell us exactly what the most limited factor is. So what can we do with the results of this test in patients with COPD with reduced physical capacity? Well, you can see here that we use a flow chart for that. And for example, if oxygen transport is the most limited factor, or the ventilatory focus is the most limited factor, we do an additional endurance test. If a patient with COPD will cope with that for more than 10 minutes or more, then endurance training is indicated in practice. If they don't get to the 10 minutes, then the interval training is indicated. And for those who are cardiocirculatory limited, then we don't have to do this test, and we know that from the literature, we can start with endurance training. So it's also guidance besides to know whether the training is safe. It's a guidance for us as a physical therapists on how to organize our treatment components. So we will still working towards the stratification of the patients with COPD. In summary, the severity of an exacerbation, with referral information most of all, the burden of disease, we just addressed the measurement instruments, the CCQ or the CAT, the physical capacity with the 6-minute walk test and the cardiopulmonary exercise test, and the physical activity with an activity checker were all considered as the important factors to stratify patients in physical therapy care. And these result in this flow chart. And in the next slides, I will guide you through the different phases of the figure. But this is a leading figure in the Dutch guidelines for physiotherapy. So at first, in the case of an exacerbation, the severity of the exacerbation is determined by the fact if the patient was hospitalized or not. In the case of a hospitalization, an exacerbation is considered as severe. In patients with no exacerbation or an exacerbation without hospitalization, the burden of disease should be determined with the CCQ or the CAT. And then we see that patients with no or low burden of disease can be classified in profile 1, and they do not need to be further investigated by physical therapists. Based on the burden of disease measurements, they do not have any complaints. And not any remarkable complaints. The patient will get, though, advice to maintain their active lifestyle, a combined lifestyle intervention, sometimes offered by the general practitioner in the Netherlands. This is an option that is offered to the patient. But this group is classified as they do not need physical therapy treatment. On the other hand, patients with a high burden of disease or patients who are hospitalized because of an acute COPD exacerbation should be referred for screening for interdisciplinary pulmonary rehabilitation. So if after this screening, the rehabilitation doesn't seem to be necessary, the patient is immediately referred to the primary care. On the other hand, if after this screening, the rehabilitation is necessary, an inpatient rehab will be given, and afterwards, mostly here approximately after 3 months, the patient is referred to primary care again. And then for the primary care, the most important block here in the middle, patients with a mild or moderate burden of disease should be referred to a physical therapist in primary care right away. The assessment on physical capacity and physical activity will take place. We discussed these two traits earlier. Well, based on the results of this assessment, patients should be classified in profile 2, 3, 4, or 5, and depending on the quadrant model we just looked at. For profile 4, 5, and 6, so you can see that those are the patients with a lower physical capacity. The cardiopulmonary exercise is indicated, as was mentioned before. And in the interdisciplinary rehabilitation screening, that is already normal in the Netherlands, but for the profiles 4 and 5, that's quite new. So that's something we have to adapt here as well. At the bottom, we see again that the degree of complexity determines the setting in which a patient should be treated. We see at the very right end the interdisciplinary rehabilitation with the profile 6. In the middle, we see the primary care. And at the left side, the information and advice on lifestyle only. Important to notice is that the end of the flow chart ideally will end at the left lower corner. Patients can maintain their own health by performing regular exercise or sports activities, but there are cases where primary care maintenance treatment is necessary. And we also discussed this with the healthcare insurance, and we have, for example, a list of examples of patient groups that will definitely need maintenance treatment. But ideally, we hope that all patients will go to the left lower corner. So depending on the profiles, you can establish which components of physical therapy the patients will need. And then in the guidelines, we can choose from the provision of information and advice to improve patients' knowledge and skills. The intervention aimed at improving physical capacity. So that's what you saw earlier, not for every patient profile. The same with the interventions aimed at improving physical therapy, only for specific profiles. And interventions focused on the respiratory system. Moreover, in the guidelines, 3 specific subgroups are mentioned, and I can't discuss this all with you, but I'm happy to guide you to the online English version of the guidelines later on, because we have therapy adjustment in the presence of comorbidity, we have therapy adjustments in the presence of an exacerbation, and therapy adjustments during the palliative stage. So those are the 3 subgroups we mentioned in the guidelines. And for the specific recommendations, well, I have to refer you to the guidelines themselves. And I have the link here as well for the English guidelines. I hope I have given you some insight in the limited time. Nirit, shall I just stop sharing and you will take it over?
Okay, yeah.
Yeah.
So thank you, Emily. And I think maybe we'll try tomorrow sending the links to through our Eventbrite app. Alex, are there any questions by now? It's a very comprehensive guideline. Very impressive.
It is. There's a couple of questions. The first one, Emily, is why do you think only 5% of Dutch people with COPD go for physiotherapy?
Well, yeah, that's a good question. I think because if you look at the deviation in the our healthcare insurance system still works, unfortunately, with the gold 1, 2, 3, 4. And doesn't take into consideration the other factors. So it's mainly the obstruction of the lung ways and not all the other factors. And then we see that the gold 1 group and former also the more light patients in the gold 2 group didn't get reimbursement for the physical therapy treatment. And then we really lose a huge group that's which are patients that really need physical therapy as well. And this is the ongoing discussion with our healthcare insurance, that it doesn't, well, should depend on the obstruction of the airways, but you have to take into account other factors like the physical activity, physical capacity, comorbidity, etc.
Thank you. And there's just a second one at the moment. So do the guidelines suggest how to handle patients with both COPD and heart failure? And secondly, does it give considerations to screening and handling of frail patients with COPD?
Well, yeah, first of all, the interconnection with from all the comorbidities, because there are a lot in the COPD population, the cardiovascular group is the main group. And we do have some recommendations on that, and it mainly focuses on the well, the signaling function. So we know that about 20% of the patients with COPD also have heart failure. and also the other way around. But there are also many patients that we do not know for sure if they have it or that it's misdiagnosed. So therefore we have a signaling function as a physical therapist, but also a monitoring one. So the recommendations also focus on not only using the measurement instruments that are described for COPD, but also looking at the other comorbidities, whether if it's heart failure, or whether it's diabetes, incorporate those into your monitoring, diagnose phase and treatment phase.
Thank you.
I'd like to ask a question, if I may. Do you have any data on implementation of the guidelines? And do you know how widely are the guidelines implemented by physiotherapists? And how easy or hard did they find implementing those guidelines?
Yes, well, that's the main focus now of the KGF in the Netherlands, because we know from the past that it was a really nice book and it went in the closet and well, that's it. So we aimed I think about 13 or 14 months now, we gave online workshops and physical workshops with all the physical therapists who have their specialization in COPD. So I think we reached about 2,000 physical therapists who have this specialization in the Netherlands. We also get a lot of questions from networks of physical therapists that want, for example, to implement activity trackers in their daily practice. And all these questions come up because of the recommendations in the guidelines. So we know that the physical therapists are really working hard to implement this. I think the most challenging one is to get it implemented with the pulmonologist and the general practitioners, for example, in referring for the cardiopulmonary exercise tests, because they all agreed on this part of the guidelines, but the general practitioners around the corner, so to say, also have to admit to this.
Thank you. So Alex, any more questions? Okay, then we can go on to our next speaker, who is Chris Burton, an assistant professor at Hasselt University in Belgium, and he will speak about the possible role of partitioned exercise training. Thank you, Chris.
Thank you very much, Neeraj, and sorry for sending that personal information so late to you, but you found it, that's good. Maybe I first want to add on one of the questions that Emily answered on why so few people are referred to physiotherapy and rehabilitation. And I totally back up the answer of Emily, but I think in many countries there's on top of that also a lack of awareness in the referring people, mostly the pulmonologists or the general practitioners, maybe depending also on whether it's the private practice or a rehabilitation setting. But I think also there's lots of work to do in creating more awareness of what we can do in these patients and what kind of effects we can have with our interventions. But that's just as an addition. So I would like to talk a little bit about the treatable trait physical capacity out of all these beautiful treatable traits, because there will be quite some people who will be referred for mostly a combination of aerobic training and resistance training, which is the state of the art, typically at a moderate to high intensity. But one of the things that we still see is that there's always also an amount of non-responders. Well, we can discuss whether these are non-responders or whether these are people that are not getting the right intervention, right dose of the intervention. But some people don't increase their physical capacity after an exercise program, and we've done some research about that in the past. And I think the onset of muscle fatigue during exercise seems to be a factor in that, in the way that we want to induce muscle fatigue and able to have an optimal physiological effect in physical capacity in these patients. With the healthy people all around here, if they do physical exercise training, aerobic and resistance training, they will induce muscle fatigue. And some patients with COPD clearly don't. And that seems to be a factor in that also co-defines the effectiveness. So therefore, I think we always have to stay creative, right? I think aerobic and resistance training are really fantastic interventions. You have to stay creative and see whether there's ways that we might be able to tackle the muscle even more in patients in which we have troubles to induce contractile fatigue, patients that do not really respond very well. And some of the things, I mean, partitioned exercise training could be one of them. There's some research in one-legged cycling, for example. So where they have looked at if patients are using half of the time in aerobic training on one leg and using the other half on the other leg, well, the power that could be reached per leg is clearly higher, and that in the end this also actually results in a higher improvement in exercise capacity. And the total time of that training session doesn't increase because you cut it in half, basically. And there's also some trials going on now on partitioned exercise training with resistance training, on training with one arm or training with one leg. This might be particularly interesting in patients that have profound respiratory impairment, people that have high breathlessness during exercise, for example. Could be interesting to work with. And I think on top of that, there's lots of other possible interventions that might target the muscle better. Another could be, for example, in eccentric training. I think a very functional example of that would be downhill walking. There's some research published in a way that downhill walking actually puts extra stress on the muscle. It even induces a bit more damage, but that doesn't really seem to be a problem on the longer term. While on the other hand, there's a lower oxygen consumption and a lower ventilation, which is really interesting for patients with COPD. And in that way, research shows that downhill walking, if you do that instead of just level walking or the typical treadmill walking, that it can induce even that it can lead to a higher proportion of people reaching the minimal important difference in terms of 6-minute walk test, and even in terms of quality of life. I'm not saying that this should be offered to all patients, but I think my message is that we should stay creative. And if we see that it's tough to get effects, that we also have to think of other ways. And well, much of this kind of interventions would typically be associated with fancy equipment, but I don't think that it has to be. Like partitioned strength training could be perfectly done with TheraBands. And if you do downhill walking, well, you can buy a super fancy treadmill that can also walk downhill, but you can also put something below in a way that they walk downhill. That's actually what we did also. And if you want to make it really functional, you could let people do stairs and go downhill. So that's the main message that I think we should stay creative in this.
Thank you. Alex, do we have any questions yet?
Not yet, no. So do send in your questions through the chat.
Everybody agrees.
So basically, what you're saying is that we should tailor our exercises creatively to the patients, which is right, and not
so,
stick with the boring old machines.
Well, yeah, I think that's also part of the solution. Indeed, that and if it's boring, it could give some variation, but indeed we should look at the individual patient, and we should also accept that one of the methods that we use might not work, and that we might have to try another approach, especially if we have the time to do that. If you have a program that runs for some months, I know that's not a reality everywhere, but it is in some countries, then you could decide on the road to also try another approach. I think the same goes for like high intensity training or non-linear exercise training. There's many of these approaches that if you look at it in research, it's so promising and everybody is wild about it. But in clinical practice, and it's also the same in Belgium and in our centers, we don't do that a lot.
One question's come in. So Chris, is the emphasis really on the big muscle groups like your quadriceps, or does it matter?
Well, I think it just depends on which kind of muscles you want to target with your intervention, right? If it's If it's about ambulation that you want to improve, then it's all about the big muscle groups. But I can also imagine that if patients have functional problems during ADL activities at home, you also might want to target the upper limbs. And you can also do that with partitioned exercise training if needed.
Okay, thank you. I think we've got another one.
There is another one that just says, do you have experience of COPD patients exercising in water?
Unfortunately, we don't have that option in our centers, but I think this is the best example on how you could individualize exercise, because this is also indeed a way which that might be really interesting in some patients, but surely not for all patients. And in that way, well, the research about it is clear that it also works, that if you do resistance training in the water, that it's really interesting to do.
Thank you. So thank you, Chris. And we'll go on to our next speaker, who is Yedidia Silverman from Israel. And he'll speak about the continuum of care. Yedidia, you can unmute. Yeah, thanks.
Thank you. So in the time I have, I'd like to go through a short journey through the continuum of care, which I've had opportunity to work in most settings nowadays, and share what I'd call my pet peeves, things that both myself and some of my colleagues find that both the patients and sometimes physiotherapists have issues dealing with, and these are problems that we need to get in again. And I think especially considering how our profession is so well placed to help people who suffer from this disease to manage it, and really improve their quality of life and their healthcare outcomes, we need to make sure that we know both where we're not doing well, and also where their challenges are, not necessarily what we find difficult. It's not often the same thing. So in the hospital setting, we often are very focused on the nitty-gritty, their symptoms, helping them get extubated, start to get them moving again. And we don't always ask why they're there. And especially in the intensive care units, we would try to understand why they had such a severe exacerbation. Sometimes it just happens, but often we would find that they're having problems with the management of their disease. Often, especially in that setting, we would have people come with carbon dioxide retention, CO2 narcosis, and very often it would be that they just aren't managing with the equipment they received at home. And with a little bit of education and guidance, and sending a technician over to help them match their mask, they can really prevent themselves getting into such a severe state with all the negative outcomes of invasive ventilation. In the internal medicine wards, we sometimes see physiotherapists, and not just, very often the doctors and nurses will routinely use incentive spirometry, the tree flow, the three little valves that everyone likes to use so much. It's not really the right thing to use for people with an obstructive disease. We don't really have any need or want to take people who are hyperinflated and encourage them to take deep breaths. They can't for the most part, and it's not their problem anyway. And indeed, in some countries, I know the Australians have removed it from general clinical practice. They don't routinely use incentive spirometry anymore. There are reasons to get them to breathe deeply occasionally, but much more effective would be to get them to breathe out. And we do very simple interventions with water blow bottles, where we take pipes and get them to really, with an external focus, and get them to really push and really get to the lung volumes that they usually don't reach. And it's often very effective, and it feels very novel to them because it's not something that they do very often. Also, people seem to like using rather complex techniques to help them clear sputum mucus, which they find both extremely unpleasant and very difficult to remember. And we generally want to give them very, very, very simple techniques that are easy to understand, where they can immediately see that they can clear some of this sputum mucus that's bothering them so much, depending if they're just coming out of an acute exacerbation, or the subset of patients that in general have a lot of sputum, especially in the mornings. In the community setting, and I think this is the thing that we find most challenging, is that these patients very often don't receive, after their diagnosis, an explanation of why they're having the symptoms they're having, and how these interventions that we're doing to them, they're receiving inhalers and antibiotics, and you have to go exercise, and everyone's throwing this alphabet soup at them, COPD, and they don't really understand what's going on. And they're often very confused, and they're just doing it because the doctor told me I have to do this, and the physiotherapist told me I have to do that. And they don't really understand how that will benefit them. I mean, there's just a very paternalistic view of medicine where we just tell them and do it. And especially since it's unpleasant to exercise for them, especially in the beginning, we really want this buy-in. And if they have a simple understanding of what's going on, we find it's often very helpful. They're very thankful. They're very surprised when we take the time to explain. Additionally, without going into details, the whole issue with inhalers is something always worth checking and making sure that your patients know how to use them. They are incredibly important, especially in the GOLD guidelines, and they need to understand that even if they don't feel that the medicine does anything, they still need to continue taking it on one hand. On the other hand, you have to make sure they're taking them properly, because I'm sure you've all seen the various, someone called them amusing, but they're very sad videos of people who probably haven't had an optimal delivery of their dose of medication for months, if not years, if at all. To close out, the people are homebound and in hospice care. This is something I feel about very strongly, and we are trying to educate our doctors and nurses. The patients on oxygen concentrators become chained to the machine, and they're very, very frightened to move around. And very often they receive from the technician that delivers it 1.5 meter or a 2 meter oxygen tube, and that's the limits of their prison cell. And if they want to move, somebody needs to get an extension cord and move things around. And simple activities of daily living, such as taking a shower, going to the bathroom, become extremely challenging. So you'll often see them sitting in front of the couch with all their various drugs sit in front of them, and they tend to stay there. So we need to know that we can do very simple interventions, such as getting them a 4 or even 7-8 meter tube, and that will give them freedom that they never imagined they could have at the late stages of their disease, and will also allow us to get them moving and exercise them. To finish, if you see, there is a recurring theme here in terms of guidance and education. I mean, besides the various interventions that we use, these are people who are lost. These are people who are meeting the medical system a lot more than the average person, even with other chronic conditions. And they very often don't know what's going on. It becomes very technical. They start getting equipment at home, which they find confusing or uncomfortable. And I think a very significant part of our job is helping them navigate this, and showing that even within all the complexity of managing their condition, they can still, have reach very high levels of self-care and activity, and that there's someone they can reach out to if need be. Thank you.
Thank you. And Alex, do we have any questions?
Yes, there's one question, which is, what do you mean by the complex and easy exercises for clearing the sputum? Can you give examples, please?
So you'll have the various, techniques for autogenic drainage with many different steps, and requires very often, more control of your body than the average person tends to need, in terms of, playing around with your tidal volume and holding your breath. I often find that the patients don't remember, and they find it's very unpleasant, and it's just very difficult to do. So we try to do very simple things with blow bottles, or sometimes not necessarily with that population, but with the cough machines for the more severe people with more severe disease, although not necessarily COPD. And we often find that just simply encouraging, a very long experience with a bit of PEEP, get them enough water, or various simple toys that you can order online, is often enough to help them mobilize their sputum and mucus, and it really doesn't require, that much complexity. One additional thing is we try to keep them from coughing more than they need to, which sounds peculiar, but trying to teach them that we want them to try to move as much of this as sputum as possible up as high as they can go, and only cough if they feel that it'll be effective. It's something that we have some success with. And if they feel that they're just coughing on empty, as we say, to try to stop it with various tricks, rest a bit, and then continue later, because we do see over time they have damage to their larynx and pharynx, and they generally have a great deal of difficulty clearing it out of their upper airways.
Thank you. Alex, I see there are some questions.
Yep, there are a few more. So if you give the patient 5 litres of oxygen with a 10-metre tube, is that still 5 litres that the patient gets at the end?
So that's a very good question. I've looked at the literature. It really probably depends on the model. I've seen it, usually they talk about 20, 30 meter pipes before it becomes an issue, but it really depends on the model of the concentrator and how old it is. Some of these things have been in circulation for a very long time. I personally you can buy a flow meter, a pen. It's like an oxygen flow meter. It's like a pen. It costs $10 on Amazon. And generally the first time I meet these patients, if they do have a long tube, I will attach it to the end, or I have my own 5 and 10 meter tubes they're prepared, and I'll attach it to their concentrator and see what the flow is. In general, outside of like some cases where the concentrator itself was breaking down, the delta is relatively insignificant. You won't see, maybe half a liter less. It's usually not a problem. A bigger problem is that many of them don't change their tubes, the longer ones, over time, and they step on them and they develop kinks and holes. And occasionally some of them will not have received all that much oxygen for a very long time because they don't know that they need to check them.
Okay, so then we've got a couple coming from one person. So how soon can you start the interventions for patients in acute COPD? And is there any kind of manual technique helping for COPD patients?
Can we, just a second, can we just leave the manual for...
Manual for afterwards?
Yeah, we'll ask all the panelists to...
That's fine.
Yeah, thanks.
So in acute care, and I'll answer also the second question I see there, it'll depend on where they are and also how the relationship between you and your team in general in the ICU, if they're mechanically ventilated. Once they wake them up, you will get them moving a bit, and after extubation, they will try to encourage you to help them cough, but they're somewhat delicate in those first couple of hours, so you're not going to be doing anything too aggressive. And at least in my experience, they generally stabilize very quickly and get moved down to the internal medicine wards. But as soon as they can move around and they're stable, the wonderful thing with respiratory patients is that it's self-limiting. They'll let you know when they've had enough, and they'll just need to sit down. I'm more worried about them getting dizzy and falling. I don't think I'm going to cause anything more than some transient hypoxia. We're not going to cause them organ damage. As to the second question,
we'll leave that to the okay. We won't go there now.
We'll come back to that.
I can talk about this all night.
We'll come back to that later. So
there's two quick ones for Yedida to answer. So is it not necessary to get the air behind the sputum with the inhalation techniques that you were just talking about there?
Yes, but if they're full of air, they're hyperinflated. So if you want to get a lot of air in them, first you need to encourage them to get as much air out as they can, again, within the limits of their anatomy and how much their rib cage has changed over time and everything else that's going on with their lungs. But someone who's has very little inspiratory reserve, you're not going to be all that effective telling him to take deep breaths. If you want him to get a deep breath, first encourage him or help him or guide him to push out as much air as he can. And all of a sudden he'll discover that he has more room, at least for his next breath, to pull in a bit more air. And yes, then we do use that to get the air behind the sputum and push it out.
And one last very quick one is...
Alex, should we first, we'll go to
Okay.
Henrik first, and then we'll see how much
Come
time,
back to that. Okay, I'll come
how
back
much
to that
time
one.
we've got later. So our next speaker is Henrik Hansen. He was smart enough to do studies on tele-rehabilitation just ahead of the pandemic. So he will talk, he will tell us about his tele-rehabilitation studies. Henrik, please.
Thank you for that introduction, Arit. Well, I'm not a magician. Actually, I just found some interesting and emergent and alternative delivery models before we all got hit by the pandemic. So yeah, for the next 5 or 6 minutes, I'll just give you a brief update on where we're at with pulmonary rehabilitation. And as Emilio also mentioned, pulmonary rehabilitation is one of the cornerstones of care of people with COPD, and there's really robust evidence that pulmonary rehabilitation improves exercise capacity and also enhances health-related quality of life. And therefore, PR is strongly recommended in all guidelines for COPD management. And I think in more than 80% of the European countries, we have implemented this outpatient model where participants usually attend 2 or 3 sessions each week of supervised exercise and self-management training for a period of 8 weeks or more. And despite this compelling evidence and its benefits, pulmonary rehabilitation is delivered to less than 1 in 3 persons with COPD who we would actually anticipate would benefit from this sort of intervention and treatment. And both referral from our colleagues, as Chris just touched upon, is challenging, but also the access to pulmonary rehab is challenged, and even more likely for those, I think, with the progressed stages of COPD. And despite this, I think worldwide global challenge, the delivery model of pulmonary rehabilitation has not really changed significantly within the last 30 years. And so some of us started to raise interest in terms of new emerging models and also telerehabilitation, which we think could have the potential to address some of the barriers of access to participation. And I think the models investigated today includes programs delivered in the patient's own home with and without technology and with and without internet access. And me and my colleagues just recently published a Cochrane review on pulmonary telerehabilitation that included 13 randomized clinical trials and involved nearly 1,300 patients with COPD. And to notice from that review was that only 3 studies, including roughly 200 patients, investigated the effect from, I think, what many people used during the pandemic, this video real-time conference system for supervised tele-rehab, while the majority of the included studies actually used a web-based instructed pages and mobile application, and participation also required that the patient had the necessary technical skills to interact independently on these sorts of websites. So definitely a huge selection from those studies from my point of view. If we look into those 30 randomized clinical trials, 50% of the studies is what we would consider progressive and with content somewhat equal to the conventional pulmonary rehabilitation programs and then the guidelines that Emilio presented earlier, while the other half of the studies concerned tele-maintenance programs, which I also think is of really high interest because we know that a lot of our patients struggle to maintain their gain benefits when they're in their programs. Also to note from the current studies and knowledge we have is that none of the studies actually included patients who were unable to access outpatient programs, and nor did the studies involve patients with ILD, IPF, and other less common respiratory diseases. So I think there's still huge gaps to close in terms of evidence and literature. The evidence that we collected for this Cochrane review on pulmonary arterial rehab actually did support improvement of exercise capacity, reduction in breathlessness, and improvement in health-related quality of life. And the effect actually appeared to be similar to the conventional program, and even with some trends to a higher completion rate in the tele rehab programs. And I think most importantly, it appeared to be equally safe even when we delivered the tele rehab on a distance. However, from my research standpoint, I think there's still a lot of uncertainty within tele rehabilitation in terms of whether these programs really are as effective as the conventional pulmonary rehab programs. And I think that's mainly due to the included studies use really heterogeneous intervention deliveries, and there are also some method concerns in some of the trials that are included in the Cochrane review. So accordingly, there's still a need for research exploring the clinical benefits, the health economy within these emergent models, as well as also the patients and the healthcare professionals' experience. So emergent models are definitely an important and evolutionary step, I think, in the development and growth of PR service from my standpoint, both with the potential to increase access, uptake, and adherence, but I think also with the potential to upskill our professions as physiotherapists. And with that being said, it's very unlikely that one new emerging model of care will suit all users. So now we have a broad spectrum of new methods, and I think we need some more research and refinement into these various models, also informed by patients and healthcare professionals' experience, and essentially more efficacy and effectiveness data to identify the most suitable models for a subgroup of patients who are unable to participate in the established program. And lastly, just to touch upon the COVID-19 pandemic, it has definitely changed the minds of many skeptics within tele rehab. And I think what's really important now is how pulmonary rehabilitation should continue to be adapted into clinical practice in this post-pandemic window, and thus continue to provide new novel models for patients with COPD who are really, really underserved. And I think essentially in the clinic, it must be supported by the evidence that we have from our current evidence, rather than clinicians do self-invented contention and hybrid models and so forth. So I think on that note, and for the sake of time, I'll leave the rest for discussion and questions. Thank you.
Thank you, Henrik. So do you think, I mean, we went all the way to tele rehab because most of us, we didn't have any choice. Do you think we are now coming back, or are we staying mostly tele rehab? And which patients should be coming physically to the clinic and which probably shouldn't?
Well, I think the questions of who's most suitable for tele rehab, we don't have any evidence to answer that question. But I think a really logic way to start is to those who are unable to attend the outpatient programs, if we still keep the established tele rehab program. In our country, we also used tele rehab during the pandemic, and I think a lot of it is getting rolled back to outpatient service, unfortunately. And I think the main reason for that is actually that a lot of my colleagues prefer the outpatient program rather than the tele rehab. And this is not a question about what your personal preference is. This is about, to reach out to more patients than we do now. COPD and pulmonary rehabilitation is really underserved. Less than 30% receive an evidence-based program, and it hasn't changed for 30 years. So I don't think we have a lot to lose. In terms of safety, it appears to be safe. and some of the studies included in the Cochrane review were actually on patients who had really progressed COPD. They were really sick, and still no higher mortality risk, no higher hospital admission risk. So my take would be to start include patients who hadn't been able to participate in a conventional program for the past 2 or 3 years, to see how it works in everyday life. And us as researchers, we need to do a more proper work on those specific groups, even though they're not that easy to get a hold of.
And did you have any conclusion or any thoughts about technology and how people manage to operate whatever system you're using? Is it difficult for them?
Well, I think the web-based programs that they're mainly used in the UK, I think that's on a highly selective population, and that's also really clear from the consult diagram. And that doesn't mean it's not important, but it's important for a highly selective group who can interact independently. When it comes to live tele rehab face-to-face, in my experience, the patients don't need anything fancy. They just need it to be simple and work just like we use Skype or Zoom or whatever. So it's stable. And then we need to be really structured in terms of the exercise program. Use same fixed exercise with a really well-described progression protocol. And again, Chris touched upon the partitioned exercise. I think that's also eventually in the future necessary to address also in a tele-rehab model if it gets implemented. But right now we need is a systematic generic model as a base, and then develop from there. Is my take on it.
Thank you. So now I really want to ask a question which came up sort of. Is there no room for any passive techniques in respiratory therapy nowadays?
I'll start, I guess. Outside of maybe guiding someone with your hands a bit, I really don't. I think also the evidence tends to back it up. And I think we've moved beyond pounding on people's back, hitting people or clapping on them. It tickles. That'll make some people cough when you pound on their back. But I think we know in terms of the physics, it's not really moving secretions around in any way. And especially in this population who might have a severe osteoporosis, and some of them are on long-term steroid treatment, you might have a small but not insignificant chance of cracking some ribs, which will make both the patient and you very sad. And I at least, again, the most dangerous words in the English language are in my experience, but I haven't really felt the need or use, and as far as I'm aware of the literature, there doesn't seem to be any particular benefit beyond what we're used to.
Emily, did it come up in your guidelines? The use of manual techniques or passive treatments? And
yeah, so we searched the literature for breathing techniques and also sputum clearance techniques, and it's honest to say that there is a lot of literature, but the methodological quality is not always that good. So what we can say from the literature, and was also shared with our experts, is that regarding the breathing techniques, it's advised to at least use the pursed lip breathing technique. There's a lot of evidence for that, but many patients already use this technique naturally, but sometimes they don't know it. So make them aware of this technique. That's the first step. If they don't use it, then you can learn this technique. And also the advice is to combine it as much as possible with physical activity interventions. But that's also what Mrs. Silverman already said, I think. And regarding the mucus clearance technique, at least use an active technique. That's very important. So we know that the passive techniques are outdated, that's for sure. And you can use a tool like a PRP or something like that to support it, but it's preferably to use techniques that patients can also use at home, because otherwise you will keep them dependent.
Thank you. Alex, I see there are some questions coming in.
There's one from a little way back that was asking about whether any of you would use strength training versus cardio training in the same session. Would you try and do it separately or together?
Maybe I can answer that one. I think, well, there's some data from sports literature, healthy people, that there might be interference when you do strength training, endurance training in the same session in terms of physiological effects, also on a molecular level, that you might block some of the anabolic effects. And there's some suggestions that, well, if you do it in the same session, if you perform resistance training first, that it might have a positive influence on the strength gain. But I think we have no idea about that in COPD. And what we typically do is probably first perform endurance training to ensure an adequate warm-up before we start doing the resistance training in these patients. And I think from a pragmatic point of view, what we see is that if we do both in the same session, that it works, that it's effective, and that it's also efficient, because typically most of the training in our patients is done under supervision, and then doing it in one session is just the pragmatic approach. But we have no data in COPD to really answer the question specifically.
Can I comment further on this? You know, because I think ideally you would use the baseline measurements that you have from a patient, right? So if you have someone who is really depleted, you would probably, you know, wait in on strength training before endurance training, because they need to get some muscle mass before they can move forward to increase their activity level and the endurance level. So I think that's actually why we also need to, as clinicians, increase awareness of test is not just a matter of measuring effects. It's also test to initiate proper intensity and weigh in properly on which sorts of exercise and also passionate exercises you should choose. So that's what I try to teach physiotherapists in Denmark, at least. So even though I agree with Chris that the most common part is that you just go 50-50. But that's not, you know, the ideal way, but maybe the realistic way.
Yeah, I was talking a bit more on if you want to do it, do you want to do it in the same session or two separate sessions? I totally agree with your view.
Yes, and the view, and Hendrik just explained, that's exactly how we recommend it in the Dutch guideline.
I know.
He cheated.
No, I haven't really read it yet. I'm looking forward to do that.
You mean you didn't read it before our meeting today?
No, I'm busy.
Good. So, Alex, and
yes. So, do you think that the provision of telehealth might actually increase the uptake of pulmonary rehab by people with COPD? Because certainly, you know, we know, you know, where I am, that people who are not feeling quite so well will often drop out and then drop out of the whole program, not wanting to sort of keep going at a certain time, and maybe telehealth might improve that.
Yeah, well, you know, time will tell. I can say from our university hospital where I work at, we have kept the Tele Rehab as an alternative model for those who are unable to participate in our outpatient program. And from it's really limited data, but roughly 50% actually agrees to participate in the Tele Rehab. So I think what the politicians really haven't giving that much thought is actually on resources, because right now we have palliative care, we have early rehab after discharge, we have pulmonary rehab, and now we also have Tele Rehab with the same resources. So we are really excited whether or not we will get the proper resources, because we increase uptake to the program. But I think Alex, I you know, it's just an anticipation that it would be able to remove some of the barriers, and you know, I'm just happy that we maintained the Tele Rehab for a really specific group of patients that are underserved in our now outpatient clinic. So
thank you. There were a few questions about relaxation techniques, mindfulness. Do you have any opinions, or can you share what the evidence tells us about them? Or are we just pushing them to do exercises and training?
At least with our work at the homebound and hospice population, where they can sometimes, depending on how they feel, have very severe symptoms. So anything that will calm them down and, you know, help them feel more comfortable, especially something they can do themselves and doesn't require, you know, an external, you know, like you said, someone else. I forgot the word in English. I think that has a place, but again, it's self-management. I think that can be useful, but it's probably depends on, you know, patient preferences otherwise.
Anyone else has something to add to that? Are the guidelines recommending relaxation techniques to be used in physiotherapy? Emily?
Yes, we do have a recommendation about relaxation techniques, but it's not backed up by good evidence in the literature. It was more based on experts' opinions and perspective of the patients. And it was also a way in which in the guidelines is referred to other disciplines. So if you try relaxation therapy, but you notice that it doesn't work properly, that you do contact the general practitioner and see if there are any other professionals need to be involved.
Thank you. Alex, any other questions coming in?
Yes, I mean, Emily's partly answered one on here, but I'll ask the other panelists. So what about upper airway clearance in COPD? Is that something to consider for prevention of exacerbation or not?
In terms of the evidence, like Emily said, I don't think there's much evidence. I mean, it's definitely worth teaching them because, again, it's more quality of life, because it's irritating and it's annoying and it bothers them that they constantly feel this stuff bubbling and tickling and that they have to cough. So it's for quality of life, fine. But in terms of changing the rate of exacerbations, I'm not familiar with any literature that says one way or the other.
So just linking into that and back to somebody had asked a question before, they were asking you, what are your techniques for stopping coughing? When you said that you're trying to stop, you know, help people stop that repeated coughing.
I studied it not so many years ago. I as a student under Nirit, so there was some talk about doing the simple things. So I just asked them to stop coughing. I said, "Can you stop coughing?" And more often than not, they just will. I mean, they might take them, you know, a couple seconds. I said, "Try to stop coughing," and they usually do. I don't have any magical, you know, tricks. I mean, that's very often, or you know, you can try some slow breathing, but you know, I'm not laying hands or throwing something at them or anything else. Very often, I think most of these patients with the chronic coughs, if you just ask them, they can control it to some extent before we start trying to do things to them. Let's see what they can do themselves.
Thank you. Thanks.
Alex, there was, I think, an interesting question to me by Gabrielius Garza about how soon can you start the intervention for patients in acute COPD, and well, that the guideline is very clear about that, because if you have a patient with an acute exacerbation, COPD exacerbation, it's wise to start the interventions as soon as possible. So of course you adjust the intensity, of course, or the location, at home therapy or in-house therapy, but also the literature is very clear about that. Start it as soon as possible. So mostly patients will ask, well, I have to do a bit slow, or maybe just cancel it and maybe next week. But this is something we advise the therapists in the Netherlands, because we know that it's not always followed up, but we know that this is really important.
So as soon as possible, get them moving and get them doing the training. Of
course, adapted, personalized to what they can do, but it's always more than they think they can do.
Yeah, thanks.
So there's one more that's probably more towards Henrik, where somebody's asking about, do you think the extra cost associated with sort of tele rehab is going to be a possible barrier to its implementation?
Not from my standpoint, if I'm the one to decide, no, but I'm not the bank. It potentially could, as I mentioned just a couple of minutes ago. I don't have any insight into the inner skull of the politicians and the decision makers on where they want to go with the implementation of telemedicine and tele-rehab. I think it would be a really huge mistake if they imagine moving the outpatient programs into the tele in terms of saving square feet and so forth. So from my perspective, it would be an increase of cost, but eventually a save of money, because it should be evident and effective in terms of health-related quality of life, fewer hospital admissions, and so forth. But of course, treatment costs.
And have you seen new technology coming in the last 2 years that make rehabilitation a more fun experience or more engaging? Are you seeing it in your countries, Henrik?
Yeah. Actually, one of my colleagues in the other part of the country, I think just last week, published on IPF, where you have this virtual trainer, and I think he found some effects from that study. So that's really more like gamification. I know that study for certain have some limitations, but you know, it's something, it's everything. It's just like a live supervision, it's web-based, it's apps, it's gamification, and so forth. And you know, I think there's a lot of fair ways to deliver tele-rehab, but from my point of view, we're still in a really early phase of which technologies to use. I think our kids, when they grow old, they will probably prefer some gamification and a lot of neat supportive systems. But the generations that we're working with right now just want technology that's really simple to use, not too many buttons, not too many fancy stuff to support them. And again, there's a few from the UK studies that prefer like apps and web-based platforms as well, but that's not the majority, I think, of the patients who are underserved.
Thank you, Chris. Thank you, Henrik. Do you see some in Belgium technologies coming in, or apps, or things to make it tele-rehab more fun?
Well, honestly, in patients with COPD, I don't think it's used a lot yet in clinical practice. There's always researchers having fun with these kind of things, but you still don't see it translated into clinical practice, unfortunately. And it's also sometimes has to do with like intellectual property. The apps are designed by someone who has the ownership about it, who can use it, who's going to pay for it. So it's the same questions that are raised.
Yeah. So Alex, any more?
Yes, there's one just come in that says, when is it advised to stop the exercise? Would it be a saturation below 87 or what?
I can comment on that from the guidelines, because we looked into this very extensively, and mostly it's thought that organ failure can occur below 90%, but well, this is a misunderstanding. although there are some reasons to say that you better stop activity if the saturation drops below the 85%. But if the patient isn't active, so it's just sitting or it's the start, then the percentage of 90% is advised in the guideline. So you have to differentiate between if the patient is active, that isn't only the treatment, but can also be, for example, the 6-minute walk test. Then the boundary of 85 is mentioned, and it's 90% if the patient is in an inactive or in a resting state.
Thank you. And I think we need to start closing. It's almost 9, well, for us it's 9:30. It's 8:30 for most. So, but before we sign off, I'd like to thank our panelists for the contribution and for the willingness to participate in the knowledge. And thank you to our Alex for bringing in the questions. A special thank you to Aitor from the ERWCPT office who organized the webinar, and it's a lot of work. To the Israeli Physiotherapy Society for allowing us to use the Zoom account, and to all who participated and who stayed that late. I hope we did something to advance the knowledge of treatment of COPD patients. So again, thank you and good night. Bye-bye.
Thank you. Bye.
Bye.